Hello, my name's Dougie Muir. I'm an interventional cardiologist at the James Cook University Hospital in Middlesbrough. The case to present is a 68-year-old gentleman who has a background of moderate aortic stenosis. He's had previous LED PCI and he has ongoing troublesome angina with a subtotal occlusion of the ostium of the PD. So this is the right coronary artery, which is pretty tortuous and slightly calcified. There's a very large PD which fills distally, and if you go very slowly through the vessel frame by frame, what initially appears to be a complete occlusion tells you there's actually a small microchannel which we can see coming off just prior to the more distal branches. And the issues for wiring this is the proximal angulation and then the almost flush nature of the entry to this vessel. So we started out with a fairly supportive guide catheter. This is an AL 0.75 6 French from the right radial, and we began the case with a cyan blue wire. So we see here the very tortuous nature of the vessel really inhibits the passage of the wire into the ostium of the PD. Even with a quite severe angulation on the wire, it proves to be impossible to engage the origin of this branch. The wire in fact repeatedly goes past the origin of the vessel we're trying to get into and goes into a more distal branch. Here we've tried to augment the wire shaping by using a microcatheter. So this is a fine cross microcatheter which is just in the bend proximal to the origin of the PDA. And even with this, with very severe angulations on the cyan blue wire, I'm completely unable to engage the origin of this branch. Here we've changed the wire to a Fielder XTA, which has got a taper tip, and we've put a very marked angulation on the distal bend, and with the aid of the microcatheter, we finally, with a significant degree of difficulty, managed to get the proximal end of the PDA engaged with the wire. We see now that the wire is running in the distal vessel, but we cannot get the microcatheter to follow into the branch to confirm the position with an intraluminal injection or to change to a softer, more friendly wire. We've now got the wire well established into the distal vessel, but despite quite vigorous attempts, it's impossible to move the microcatheter beyond the origin of the PD, nor to get the smallest balloon into the origin of this. And at this point we have a problem because we can wire this vessel but cannot get any devices to cross into the PD itself. With the aid of a guideliner catheter backup device, we managed to get the Corsair microcatheter to torque its way across into the PDA origin over the wire. And we can see that the Corsair is now in the PD, and we have an intraluminal injection to make absolutely certain that we're in the right place. Here we've used the Corsair to swap to a softer wire. We've gone back to the cyan blue, and although the torqueability in the distal vessel because the tortuosity is still difficult and we're in a small side branch rather than the main vessel, we can be confident that we can now balloon this. In addition, the Corsair has already made a channel into the PD, so we can start off with a 2 or even a 2.5mm balloon, which you see here. After further pre-dilatation with a 2.5mm balloon into the PD, we place a second wire into the PLV for security, and we can now deliver a 2.75mm drug-eluting stent to the PD. And this is the final result, with the successful delivery and implantation of a 2.75mm drug-eluting stent, post-dilated with a 3mm non-compliant balloon, with a good result in the PD and no significant compromise of the PLV. So this case was very challenging. The first problem was engaging the ostium of the PD with a wire, which proved very difficult and required various wires with different bends. Once we had got into the PD, the problems continued, and it was essentially impossible to track any device across into the PDA origin because of a combination of the vessel itself with the calcification and tortuosity proximally, and also the tight lesion at the subtotal occlusion. We were able to use the Corsair to cross this by using the torque transmission by rotating the Corsair on the wire, and this meant that the taper was able to engage the origin of the PD and get into the vessel itself. We could then use this to swap to a softer wire and continue with a standard angioplasty from that point.